Good afternoon. I should thank the organizers for giving us an opportunity, Amitabh and Sanjeev and everybody on this wonderful occasion. I'm here to share experience with my valve in 80 position, PA. I'm so proud about this valve because it's an Indian valve, and so sort of be able to save a lot of children with this, not adults with this disease. So I should acknowledge all the operators who have been around India and also abroad who have been part of this, and we have done around 28 valves so far around India and other places. Disclosures. So the prevalence of congenital heart disease increasing in adults. If you look at our Indian population, we are our congenital heart disease, particularly in adults, is growing up in a rapid phase, and we'll be facing more and more of patients needing RVOT issues like valve implantation for surgery in next 5 years on the line. And most of them have got all 20% of newborns are RVT anomalous. So we have an issue here, and significant PR at 2 years of age, and surgery is often sort of delayed due to a lot of reasons, and morbidity adds on to it, and delayed surgery causes irreversible RV dysfunction. So the valves currently for pulmonary implantation, we have as Shiva's talk, we already shown self-expandable and balloon expandable valves, and I'm going to speak on the my valve. So these are some indications of cephalic melody, and we can see that there's a limitation of size. RVOT being less than 27 mm is a limitation of size. And this is the most commonest of all the patients who will be requiring pulmonary implantation. And what are we doing to do this? Is self-expanding valve is an answer to this. I'm afraid it's early to say, because huge RVOT with loss of energy by eddy currents, and also having a stent sitting in the RVT muscle and preventing of RV remodeling and arrhythmias is a concern. So my valve has been in the market since 2019, and we have done about 6,950 implantation all over the world, and we got good experience with this, and it's got a cobalt chromium frame, which is very good on an ATPA, and it's got an incremental size from 20 mm to 32 with 1.5 mm incremental sizes. And we published a first paper in a conduit in 2019, and this is the first my valve implanted, and with good results, and should be under follow-up. And it's an interest case of an ATPA, which I did in 2020. She's a 15-year-old lady presented with breathlessness, and she had an early tetralogy fallow, for which she had a surgery done, and then but she didn't have further surgery and was not on a follow-up. And she came with breathlessness and was on atrial fibrillation and also right heart and left heart failure. So she was referred to us for a pulmonary implantation because the high risk for surgery. The CT scan forms a major role in our landing zone assessment. We have multiplanar review mode where we look at the narrowest zone, which should be 2.5 centimeters from the branch PAs to have a stable valve position. Then we go for a measurement of the size, and we always go for the area rather than diameter. Area should be less than 710 millimeters square for implantation, because the largest available valve, 32 mm valve, which can go up to 34 mm, and the nearest coronary artery is also identified in the CT scan. So what we do is we access the vein, right artery, right femoral vein, left femoral vein, and we do pacing via the left femoral artery into LV pacing, and left femoral artery is used for the coronary artery cannulation. So hardware, importantly, what we have got a wide array of covered stents available, and we have the ZMED balloon 30 by 50, because that's the one balloon we assess for the stretchability of right ventricle as RVOT. And this is a list of hardwares. So we do 2 injections in RA over 30-30 and lateral view to look at the orientation of the right RVOT. Then what we do is we position the wire. This is very important procedure, because you have to have the wire deep inside the LPA. We have a 2-wire technique where we have a sound punch guide through which we take 2 wires. First of all, we take the thermo wire. Through this, we take the Lunderquist wire. As we pass the guide, we pass the Lunderquist wire through deep into the LPA. Once we secure it, okay, then for balloon sizing, I always test the balloon sizing under rapid LV pacing. A lot of comments and things about why should we pace the RV. I consider RV as equal as LV can produce a pressure 110. In our valve implantation needs a good stretchability to look at a valve. If the balloon moves up and down, we cannot measure it properly. So we go for a good stretch, looking for mild waist. We measure the waist and also do a coronary angiogram simultaneously. Once we have done that, we upsize it more than 20% to that wall at the area. Then we go for the valve implantation. It's also done in rapid LV pacing. We do 2 injections first to start with. Halfway through, we do 1 more injection, and then we go for the full implantation. So once we know that we are approximately narrow zone, we go for full implantation. So this is your post-implantation valve being a coronary artery is no obstruction, and there is an angiogram to show there's no parallel leak and good result. And this echocardiogram the next day showing a very minimal PR. So I'm just going to quickly go through a couple of examples. This is a child, again, a 14-year-old was referred to me for a pulmonary implantation. One important thing I can notice that here the bifurcation, the landing zone was only 2.12 centimeters. So that's something should be concerned because the balloon won't have space to expand. It can push the valve down. This is our early part of our experience. So we did angiogram in three different views to look at the narrowest point, and we measured 28.2, and we took a 32 valve, which is the largest one, and took the valve across. As we inflating the valve, the whole system came down from the narrowest point. I anticipated that, and what I did is I took about 15 ml extra to the volume of the balloon and tried to maximize the balloon's valve size. So we jammed it across RV, just above the RV muscle. And once it stuck there, the valve was there. But what happened is it had a moderate PR, which we didn't accept. So we took 1 more valve inside, and then it was implanted. And that's the result post-implantation. If this happens, it will ask you 2 valves are charged. Only 1 valve is charged by the company. So this, when the faulty valve or have issue, the company charges for only 1 valve. So next patient is again a hugely dilated RVOT, and landing zone is very close to bifurcation. So I anticipated a embolization in this one. So here I didn't want to do the same thing. So what we thought is we should have a stabilization stent. So we went to the left side. You can see the balloon sizing. There is no tight sealing at all. RVOT is ballooning around it. So we cannot implant a valve above in the NTPA. So what I did is I went inside the LPA. We took a Zephyr stent, which is 59 millimeter length. We went with 24 balloon, and then we dilated, put a stent across in the LPA, and then we further dilated the proximal flare by 30 mm Siemens balloon. Then we took a you can see took a Atlas balloon, which is 24, and dilated the entire LPA. And then we went for a valve implantation, and you can see the valve coming, and we made sure the upper part of the valve is tagged on to the stent, and this is a result post procedure. So whenever you don't have a proper landing zone, which is quite close to bifurcation, you need to anchor to one of the branch PAs. Next patient is an MPA, the child who has got 10-year-old who had bilateral branch PA stenosis. And so they got a good landing zone, but had a very severe branch PA stenosis. So we wanted to do everything in one single setting. So went for bilateral branch PA stenting with 10 mm by 20 millimeter Cook's formula stent. Went for simultaneous inflation, and good result. Following that, we did crushing technique to crush the stent in between, and then for a valve post implantation. This is a child from Nigeria. So we have to implant a valve before she goes home, and it's a very good result post. And the IV pressure was normal post implantation. So our experience, we have 27 patients so far, 20 were in ATPA, 15 had successful valve implantation, 2 were declined due to upper balloon sizing. Our experience is growing now because then we have to have alternate strategies of doing now. 1 valve got embolized, early experience, and we sent for surgery. 1 had abandoned because we had difficulty taking valve across RVOT. So we have to abandon the procedure. But now we have an alternate source having a long Python sheath coming up. So we could use it for taking the valve across RVOT. 1 is declined due to coronary compression. So average size of valve 30.5 and most common valve 32 mm. And we have shown that 5 ml increased diameter of the normal volume of 30 mm increases the diameter to 33. 10 ml increase 34. So up to 34 mm, we could safely implant a valve. So this is the data of us showing a good result, and the follow-up duration from 18 days to 2.5 years, and we have good result with an ATPA. And that's what we recommend now, a 23% increase from the balloon sizing essential for a stable valve position. And that's the emblazed valve, and you can see that, that's very close to landing zone. It's not playing. So anyway, and we have got techniques to push the valve across. We have for balloons assisted techniques where we push and pull the balloon across to take it. But with the advent of new long Python sheet, is under trial. We have used on 4 patients doing well. I can't show the images to you, still isn't copyrighted. So, but this long Python sheet is available soon to for us to use it across RVOT. So we published results recently in Annals of Pediatric Cardiology and recommended that we should oversize by 20-25% of the stretched balloon diameter. So in summary, we have growing number of patients needing pulmonary implantation. Surgical are good, although morbidity is very high. Defining the landing zone is very important. My valve, I'm so proud of my valve. Need question really wait for the to be based on RVOT rather than RV dilatation, and something you should think over in future. Thanks for listening. Thank you.